Okay, well, hello and welcome. I am Cassidy Avila with the Center for Optimizing Rural Health, and I'm pleased to welcome you to this webinar on Medicare HMO contracts. I'm joined by Mr. Paul Delaney with Lester Miller and Wells CPA firm, who will be presenting the webinar today. And I will introduce Mr. Delaney in just a moment, but first a few housekeeping items. We are recording the webinar and we will share it with you. Give us about 24 hours to get it posted to our website, and you will receive an email from CORE with a link to the recording as well as a copy of the slides. We will have time for Q&A at the end of the presentation, but you may go ahead and drop your questions into the chat box during the webinar, and I will make sure they're addressed during Q&A. You may also unmute during Q&A and just ask your question, or send it to me directly, and I would be happy to ask it on your behalf. So now it is my pleasure to introduce Paul Delaney. Paul earned his BSBA in accounting in 1990 from the University of Louisiana at Lafayette. He has practiced public accounting at Lester Miller and Wells since graduation from college. And in 1993, he earned a CPA license, and in 1998 became a principal of the firm. His areas of practice include auditing and accounting, third-party reimbursement, and taxation. The majority of his practice is related to healthcare, ranging from rural hospitals to freestanding rural health clinics. Paul is a member of the Louisiana Rural Healthcare Association, the Louisiana Hospital Association, Healthcare Financial Management Association, the American Institute of Certified Public Accountants, and the Louisiana Society of CPAs. He has spoken at seminars related to healthcare accounting, auditing, and third-party reimbursement, sponsored by the Louisiana Rural Health Association, Louisiana chapter of HFMA, and Rural Hospital Coalition Incorporated. So welcome, Mr. Delaney. We're so pleased to be here for your presentation. We thank you for your time, and I will hand it over to you now.
Thank you, Cassie. I appreciate being here. Can you hear me good?
Perfect.
Great. Okay. Before we begin, I just want to say it's good to have a little bit of break in this weather. I never imagined being in the 90s feeling this good. We did get a little rain here, not much, but in the past week or so, it's like I've been running to the gym just to go to the sauna to cool off, seems like. But okay, enough with the dad jokes. I'll move on. Cassie asked if we could speak on the Medicare HMO contracts. So if we go to page 2 of the slide, Cassidy. The main reason is because the growth has been, it's been very huge in certain hospitals. I've seen it over the past 10 years. It really depends on the region you're at or the location. It depends on the insurance companies, how aggressive they're getting. An example is Medicare recipients. They're being solicited by these HMOs where traditional is not doing any solicitations. HMOs have offered different types of coverage that appeal to the recipients. I've heard of HMOs providing for transportation, health club memberships, cash for groceries, etc. So when you weigh that versus being on traditional, you'll see a switch to the HMOs. So go to the next slide. Okay, this is just one of the hospitals I looked at. And I looked at the percentage of Medicare charges to total charges. So in 2019, traditional Medicare represented a little over 38%, where the HMO population was only 5.5%. And you could see from 2019 to 22, the traditional has been going down every year. The biggest decrease was in 2021 when it went from about 33% to 28%, where the HMO went from 10% to 15%. So if we go to the next slide, you could see the traditional has been going down 2.6%, 3%, 5%, and 0.8% of total charges, where the HMO growth was 2.8% in 2019, 1.5, 5.1, and 1.3. And you could see 2021, it wasn't, the overall Medicare did not decrease. It just switched from traditional to Medicare. So we'll go to the next slide. And if you look at it, this is just a graph where red represents traditional and green represents HMO. And you could see from 2019 to 22, the growth of the HMO has been going up and the traditional has been going down. And so let's go to the next slide. This, and I know I'm beating a dead horse here, but in 2018, you could see the HMO was just a small piece of the pie for the total Medicare population. And if we go to the next slide, you'll see that 2022, all of a sudden they're getting closer to having almost 50% of the Medicare population. I would imagine in 23, 24, you're going to see that growth get closer to 50%. Let's go to the next slide. So what does this mean as far as concerns? Another payer means more work. So we have more contracts to negotiate, and these contracts are going to come from the HMO. So it's going to take administration reading through each of these. Potentially more staff may be needed in the business office. Another payer, I mean, we've seen this in Louisiana where Medicaid, not only did they do an expansion, but they also decided to farm out a lot of it to the HMOs. They created now 6 different insurance companies they have to deal with. Also, the oversight of the reimbursement, that's going to add some more work. Your insurance companies typically have a different criteria for medical necessity. They're going to be profit driven, so they're biased in these decisions. And it's a little risk that the insurance companies could go bankrupt. It's a minor risk, but that leaves mainly the providers holding bucket there. Let's go to the next slide. So let's talk about some items typically paid by traditional Medicare, but not always paid by Medicare HMO. Medicare bad debts. Traditional Medicare will reimburse a Medicare bad debt up to 65%. There's going to be some cost reimbursement items that aren't paid by the Medicare HMOs. A good example is in the rural health clinics. Traditional Medicare pays for flu and pneumonia vaccinations via the cost report, where you're not going to find this in your Medicare HMO contracts. Additionally, current cost is not paid. It's usually based on a previous year's cost report. So we'll go to the next slide. The timing of submission of claims. So this is some of the contract language I looked at in one of the contracts for a client of ours. The HMO wanted the provider to submit claims within 60 days. Medicare traditional allows up to a year to submit a claim. They didn't limit it to the 60 days. They just said they prefer to have it within the 60 days. The only thing I didn't like was upon the termination of the contract, the provider had only 60 days to submit the claims. So when you receive a contract from a Medicare HMO, remember, they wrote the contract. So a contract needs to be fair between both sides. And here in this case, I think 60 days was not long enough to submit claims. I think it should be 90 or 120 days. So it wouldn't be unfair just to ask for a longer time period. Go through those contracts, mark up your concerns. One of the things that was missing in this contract was timely payment of claims. So they wanted you to submit the claims timely, but they didn't mention anything about how fast they would pay the claims. Again, when we talk about contracts, you want to be fair to both sides. It's kind of like a hospital contracting with a physician. Both sides have to be in agreement, have to be fair to each other. Next slide. There was a clause in there for billing secondary and non-covered services. You should have this in each contract. The provider should reserve the right to bill secondary payers. Provider reserves the right to bill enrollees for non-covered services. So make sure that's in your contract. Next slide. And I know I'm going through this kind of fast, but if there's any questions, let me know, Cassidy. Providers authorize agents. When I was reading this section, I noticed that they had language in there that the provider should be bound by all actions based upon the instructions and representations of the provider's authorized agents. The problem was they didn't define who the authorized agents were. I think you should define that, and any instructions given should not be contrary to the agreement. Here I was concerned about anyone in the business office that's dealing with the Medicare HMO, and they give them some instructions or provide some type of interpretation or representation that would be contrary to the agreement and hold them bound by that. So in this one, I just asked them if they can write in the names, or say it's the CEO and the CFO that are only authorized to make these actions. Okay, next slide. So most of them they'll have where they'll have some type of language saying that the Medicare payment will be adjusted due to changes in legislation. This payment can be adjusted up or down. The only issue I had with this was the HMO had reserved the right to modify the payment and how to implement the change. So again, they have full control where the provider's not having any say. You may want to look at that and try to come to some kind of agreement with the HMO. Okay, next slide. Payment rate. So this is on provider-based rural health clinics. And typically what you'll see is the HMO will pay the provider 100% of the Medicare allowable encounter in effect at the time of the cover services provided. So this payment is considered an all-inclusive counter. By doing so, they're saying they're not going to pay the flu and pneumonia vaccinations. May not be much, but typically a flu vaccination, what I'm seeing, ranges from $60 to $90 in cost reimbursement, while pneumonia will go anywhere from $200 to $250. Let's talk about a little bit more about the timing of that payment on the next slide. So let's assume your cost increases each year and it's completely allowable for Medicare traditional purposes. It's under the upper payment limit. So provider will submit a calendar year 2022 cost report by May 31st, 2023. Typically, the intermediary will perform a tentative settlement and issue a new payment, let's say around July, late July, early August. It may go into September, depending on how far they're backed up. Therefore, your new payment rate's not going to come in effect until, let's say, August of 2023. And therefore, we're paying claims on 2020 using 2022 costs, and we're already more than halfway through the year of 2023. So let's look at an example starting on the next slide. Let's say in 2022, your cost per visit was high, $250, And the reason it was high that year was you had COVID. Your rural health clinic visits had decreased because people were scared to come to the doctor's office and were scared to contract COVID at that time. So we saw the cost per visit go up. The upper payment limit came in effect on April the 1st of 2021, and it is increased by 1.4% in 21 and 22 by 2.1 in 2023. So the very bottom, you see your upper payment limit went from $253 a visit to almost $269 a visit. However, your cost per visit in 21, let's assume your visits increased back in 21 and your cost per visit was $180. But in 22, because of inflation, nursing salaries, etc., it increased to $200 and then to $210 in 2023. So if we go to the next slide, the Medicare payment was $180. The RHC is being paid $180 from 8/1/2022 to 8/1/2023. That's when you file the 22 cost report and you find out that it's $200, and then therefore your new payment rate in 2023 in August goes to $200. So let's go to the next slide. Hopefully this will make a little more sense. So in August 1 of 2022 through December, let's say you had 3,000 visits for Medicare HMO, and then the next period, let's say you had from 1/1/23 to 8/1/23, 4,800 visits. So your payments from Medicare HMO would be $540,000, because remember, it's being based on the 2021, and then your payment, you get a payment update to $200, so you get $864,000. Yet your costs have gone up, so therefore you've lost $60,000 in one period, $144 in the next. So what can we do to fix this problem? Let's go to the next slide. What we can do to kind of help matters is we can ask the Medicare intermediary to adjust our rates in the interim. So what you would need to do is do a kind of a mock cost report or some type of interim calculation halfway through the year and look at your costs and say, okay, based on my costs and my visits, my cost per visit went up, submit it to the Medicare intermediary and see if they can do a rate adjustment to get it up. So we go to the next slide, and you could see if we were to, let's say we were to nail it right on the head and we were able to get the $200, then for that first period, what you would receive would equal your cost. Your second period, you still be behind, but the loss would not be as bad, and you would actually have a pickup of $156,000 compared to the previous periods. I know I went through that fast. Just take your time and kind of go through it, and you'll see the calculations I made and the timing of it. But if you do nothing, you're going to be about 2 years behind in your cost. So let's go to the next page. Just a warning. Even if you do interim rate calculations, you could still be underpaid because that interim report is just an estimate. For the vaccination, see if the HMOs will bite off on paying you a lump sum, just taking the number of vaccinations times the current year cost. I don't know if they'll go for it or not, but it's worth a try. So on the next slide, let's talk about critical access hospitals and how they're paid. They're paid basically a set rate for acute inpatient and swing bed. Costs can fluctuate significantly up or down. I mean, for example, in 2021, in 2020, your cost could have been per day could have been kind of high. In 2021 and 2022, it could be your cost per day could be actually a lot lower because of the number of high COVID admits you've had and the number of patient days. So the more patient days you have, the less cost per day. So if you look at 2023, your cost per day could significantly increase due to days decrease. I kind of got an error in there. I just noticed that. So just think about it. If you take your total cost, divide by your patient days, you get your cost per day. And if your days decrease significantly and your costs remain about the same, your cost per day is going to go up. But if you're being reimbursed on something from the past, then you're going to lose out. Also, just to let you know, the HMOs can be looking at the swing bed because your swing bed is paid based on cost reimbursement or cost per day. They could potentially steer your patients to other facilities that are being paid on rugs where they'll have a significant savings there. So next page. Example of increase in the cost per day. As you can see, your inpatient costs, if it's going up just slightly from 2 million to 2.1 to 2.3, but your patient days were 1,021, 922, but in 2023, because COVID wasn't prevalent, natural population, let's say, is healthy. Let's say you only have 500 patient days. So your cost per day went from $2,000 to $4,600. So if we look at the next slide, we can see that in 2023, the provider would have been paid on the $2,000 per day until that tentative settlement's made in August, but only increased to the 2022 cost report, which is $2,333 per day. Since the cost per day is $4,600, this loss can be significant. Just on 50 patient days, that will result in a loss of $123,000, where your cost was $230,000, but you were paid $107,000. So in traditional Medicare, we would run this through the Medicare cost report, and we would receive that extra $123,000 in reimbursement. A long time ago with the Medicare HMO contracts, some of them allowed for cost reimbursement. I haven't seen that in a good while, but if y'all are able to write that in the contract, that would be just a simple calculation where you take the cost per day off of the Medicare cost report times the number of days they have compared to the payments, and maybe you could come up with a kind of a settlement there. Now, granted, that could go up or that could go down because the years where you have more volume, you tend to be overpaid. Next slide. Okay, this on PPS hospitals. The inpatient reimbursement can be composed of several types of payments. You got the dish where you got an old formula and new formula. You could have technology payments. You could have Medicare dependent versus sole community rates and low volume adjustment. So there's a lot of factors that play into how a PPS hospital gets reimbursed. And so we need to make sure that the HMOs are reimbursing us similar to the way traditional is. So let's look at one of the issues we could have on the next slide. Is the low volume adjustment. Congress let this expire last year, October 1 of 2022. And what was going on there was we were in the middle of midterm elections. Therefore, Congress I hate to say it, is kind of a do nothing. So any bills out there, they'll let expire and they'll address them later. Congress approved a 2-year extension on the low volume adjustment at the end of December in the omnibus bill that was signed into law December 2029. 29 of 22. Medicare the traditional Medicare, what they did was they reprocessed the claims. I believe they started in February of 23, reprocessed those claims, and new claims coming forward, they had that payment adjustment. This payment adjustment just varies, depends on how much volume you do. And it goes based on discharges. So if you're under 3,800 discharges and you're not within 15 miles of another subsection D hospital, you would qualify for this additional payment. Most hospitals I see get anywhere from 15 to 25%. Rural hospitals I'm referring to. So if you're saying a 15 to 25% add-on to Medicare DRG, this is significant. So how did the Medicare HMOs respond to this? One of our clients, we found out after the fact that the HMOs forgot all about it, and they were underpaid for those claims, and they had to come back and settle up with them. So if you're not watching them, we can leave money on the table. I know even I do this issue. When we talk about low volume or other factors that affect a Medicare cost report or Medicare traditional claims, we zone in on Medicare traditional and we forget about the Medicare HMOs. Maybe because it was a small part of the pie, but because that pie is growing and getting bigger, we need to make sure that we're getting paid similar to them. Next slide. Okay, I'm sorry. I forgot I had this was all of what I had to present. I know I went through that very quickly, I guess because I got nervous. I had a little bit of internet issues right before it. And then on top of it, our office is getting pressure washed. So I got a sound of a pressure washer behind me. And I appreciate y'all hanging in there with me. Are there any questions for me, Cassidy?
Thank you, Mr. Delaney. Yes, there are a couple of questions in the chat, and just so you know, we could not hear the pressure washing. So our first question states, can you address the concerns of providers primarily in rural areas that are dropping their contracts with Medicare Advantage plans?
So on the question, to make sure I understand the question, so you may have some providers dropping Medicare Advantage plans?
Yes, sounds like.
So if you're dropping the Medicare Advantage plans, if you're a PPS hospital, I would believe you're leaving money on the table because you could have potential admits and stuff. If you're a critical access hospital, maybe you're trying to keep your population more Medicare traditional to improve your cost reimbursement. I understand that, but I would negotiate with the Medicare HMOs or Medicare Advantage. There are certain contracts out there where Medicare Advantage or some of the Medicare HMOs, they have to pay X% in claims. A portion of that could be they got to pay so much for managing the care. Maybe you can negotiate something to help them manage the care of their patients. I've seen some where they've even done a full risk contract where they share in that payment. So let's say from Medicare, the HMO gets a certain payment for managing those patients and managing their care. You could actually share in that payment. Okay.
Thank you. And then the next question states, what is the best way to get the HMO to pay off? Oh, lost the question with another one. To pay off the Medicare rate letter and not to try to pay based on the traditional PPO rate.
Good question. So once that interim rate letter is in effect, according to the contract I read, it did say that they pay, hold on, let me pull it back up. They pay based on the Medicare allowable rate in effect at that time period. So if Medicare issues an interim rate letter, they should pay that according to the contract, if that's in the contract language.
Thank you. And then another question just came through. Do you know which HMOs are more critical access hospital friendly?
No, I don't. I wish I knew which ones were friendly and which ones weren't. But that is a good question. Just remember, when you're negotiating with them and contracting with them, you got to come to the table and say it's got to be fair on both sides. You're providing the service. I know they have the enrollees. They want to make sure their enrollees have access to care. So if your hospital is 30 minutes plus from another hospital or from an urban area, you have an advantage there. And you need to remind them of that. You need to tell them, Medicare traditional pays this. You should be paying similar. And we have to fight for every dollar. Okay.
Another question just came through. Might be a little out of your wheelhouse, but is there any way I can push back against HMOs requiring modifiers on charges that Medicare doesn't?
Oh, yeah, because that's more of a billing question. So that is out of my wheelhouse. It depends on what the modifiers are being used for. If it's to improve your reimbursement, you want to make sure those modifiers are there. If not, just what are they using the modifiers for? Maybe they're using those modifiers in their way of trying to give me a second. In managing the care of their patients. If they're using those to manage the care of their patients, then there should be room, if you're going to do that, for you to get paid for doing that work.
She says they've been anatomical modifiers for lumbar injections. It's impossible for our coders and billers.
Okay, that one's out of my wheelhouse. I wish I knew.
Heather, I'm just going to make a note. Send me a message and let me know what facility you're with, and I will try to pass your question along to a coding and billing person that might be able to answer. Okay, so those are the questions that we had already in the chat. You still have plenty of time if you want to drop a question into the chat or unmute yourself. You can absolutely do that. And in the meantime, while we wait for you to gather your thoughts, I'm going to drop a survey link into the chat. And this is just a general survey on the webinar and what you might like to see in the future. If you wouldn't mind taking a moment, I'm going to double check back in the chat and make sure we don't have any other questions. A couple of you asked about getting a copy of the slides, and yes, Mr. Delaney has shared a copy of his slides. We usually send those out after the webinar. That way we can make sure it goes to everyone who registered right up until the last moment. And so I will share that following this email. Like I said before, if you give us about 24 hours, that will allow time for the webinar recording to be posted to the website, and then we'll share the link to the posted recording as well as a copy of the slides for you. And still no questions, so I'll just keep, okay, here's one, perfect. What can an organization do within the law to communicate with patients regarding choosing their Medicare plan? Oh, you're muted, Mr. Delaney, you're muted.
Sorry about that. Within the laws, there shouldn't be an issue with explaining the benefits of Medicare traditional versus Medicare HMO and what they offer. I do know you can explain to them Medicare HMOs typically pay for these services. Here are some that we've had issues with them paying. But yeah, you can explain just basically the pros and cons to the Medicare traditional versus HMO. However, you cannot do any disinformation or slant a view toward that.
Thank you. Okay. Any other questions? If you think of a question after we end this webinar, please don't hesitate to reach out to someone here at CORE, or Mr. Delaney has been kind enough to include his email address on the slide that you see right now, and so you have that opportunity as well. Any final questions or thoughts? I'm happy to give you back 20 minutes of your time, but if you have anything, you might as well take advantage of this. Adding on to that last question, not a question, but a comment. Some Medicare HMOs do offer add-on payments for closing care gaps and reporting QMs without risk. Thank you for adding that, Harold.
That's a good one, Harold. Any additional payments they offer will help that as far as closing the difference between Medicare traditional payments and Medicare HMO. Like I said, a long time ago, when these contracts were first coming around, they pretty much mirrored Medicare traditional, where they did some cost reimbursement, they did some reimbursement of bad debts, but along the way, they have dropped those payments off. And I've seen more where they just want to pay a set rate and be done with it. My main concern is monitoring those contracts to make sure you're getting paid the correct rates, particularly in PPS hospitals, where you have the additional payments, such as the low volume adjustment, the Medicare dependent or Medicare, the sole community payments. If you're getting those, you should be getting them through your Medicare HMO payments. And if you don't monitor it, a year or two could go by and you're trying to figure out why the payments had decreased so much. And that could be one of the issues.
Our last call for questions. We appreciate your time today. And like I said, tomorrow be looking for that email and reach out if you have any questions, but I don't see anything else in the chat. Mr. Delaney, thank you so much for your time and expertise. We really appreciate it. And I think we will go ahead and stop the recording and then let you have about 20 minutes of your day back. But thank you so much for being on the webinar with us today, and we look forward to seeing you on the next webinar. Bye, everyone.